major bone defect is mainly in the lateral femur, distal and posterior. As we see here, tibial bone defect is usually contained. We do not go into the details of the tight lateral structures, but what we need to see is a competency of the MCL. So these are the 2 points only which we need to keep in mind when we see the valgus knee. Correctable versus fixed. So very important. If it's a correctable, it means it's a defect management surgery in a lax knee. And if it's not correctable, it's going to be having a different protocol which we are going to see later on. So if it's a correctable, cut less because it's a lax knee, fill more and align properly. As with all the other knees, varus or other, if it's a FFD, you have to be careful, cut less, be aware about peroneal palsy. If it's recurvatum, FFD, cut more. If the recurvatum, cut less. Extra-articular deformity, you can see, I think Dr. Hemant is going to have a detailed talk on to that, but just keep in mind, if you have a valgus deformity along with extra-articular deformity and it's more than 20 degree near to the joint, it may require osteotomy. Not too much go into the detail because there's a talk coming. Important another clinical point is hind foot deformity, because the flat foot is sometimes you see with the valgus knee, and overcorrect the valgus deformity whenever the foot deformity is present. So these are the important clinical points when you see the patient in the examination room. As we all know, most of the cases are done by medial arthrotomy. Do less medial release or no medial release, right? You are all used to do lot of medial release because most of you see the varus knees. Your entry point has to be slightly medialized based on the valgus correction angle. So in here, it is usually less compared to varus. Be careful about that. We all know about these cuts. So the tibial cut perpendicular to the anatomical axis, as I said, you take 3 degree of the VCA, do the femur cut, and you get this type of trapezoidal gap. And what we do, we try to correct and convert this trapezoidal gap into a rectangular gap in extension with soft tissue balancing. So this is the time where there is a role to do this all soft tissue release which we all know about, like release of ITB or posterolateral capsules and POL, and convert like into this. But avoid release the LCL and popliteus. These are the 2 structures we try to avoid in the valgus knee because it may cause late instability. So cut the PCL, you all know, and this dots suggest that you do the pie casting of the IT band with a varus stress with 15 number blade, transverse cut of the posterior capsule at the joint line with the cautery from PCL to ITB. You release that. Again, I'm repeating, do not cut the LCL or the popliteus, and recheck the stability at every time. You have done the bone cuts, you are now balancing in extension with the soft tissue only and releasing in extension. These soft tissues, you get a proper shape. Now you come to the flexion balancing. Usually the lateral condyle is hypoplastic. Flexion balancing, you don't do any soft tissue. It is only the rotation of this. Now here you see, if you cut the line like this and you put your jig and touch it to the lateral condyle also, the jig at the posterior part, it will have an internal rotation part. So be careful when there is a hypoplasia, and what we do is a parallel tibial cut technique or a freehand rotation, and make sure that your parallel tibial cut or a free rotation brings this. Just see this, it should be like that. So don't touch your posterior part of the jig to the lateral also because there is a hypoplasia. So you just keep it only to the medial side, otherwise you will have a wrong rotation. And the flexion balancing is done by the rotating so that you make your parallel tibial cut accordingly. You can see here, you are cutting less on the lateral side, right? And you are cutting more on the medial side. And this is what we do and make a parallel cut dynamic rotation. Avoid any soft tissue release in the extension. Now, even after doing that, you are not able to balance, then you have option of 2 things. One is, as I said, lateral sliding osteotomy or a constraint implant. This is what we need to achieve in flexion, parallel tibial cut, and your bone should be like this. If you do insufficient release in extension, your post-operative X-ray will be this, tight on the lateral side. So, and it will lead to a failure. And if you do too much of release, you will have instability like this. Because of the bone loss, as I said, lateral femur condyle, distal and posterior, you may end up in having a bone defect there. So you might need an augment, and similarly, or a bone graft. If the tibial bone defect is there, you might need a graft, screw, and defect management we all know about. But these are the common two defects. Sometimes the tibial defect is a contained, and if you put a bone graft or something, you might have to put a rod also. This is what exactly we want, a good patellar tracking, well balanced knee. You can see there is a bone graft on the lateral side, the knee is fairly balanced, AP, lateral and patellar view. But we often see the mal-tracking of the patella in the valgus knee because of the excessive Q angle, tight lateral retinaculum and excessive tibial torsion. We all know about the lateral release, and we always see sometimes after the post-op there is a big swelling coming on the lateral side. So there is a technique suggested by various authors, the paper by Dr. Maniyar also, which is known as outside-in technique. So do not release the retinaculum from inside, just do it outside. It's a 3-step technique, and you don't encounter that bleeding or the swelling on the lateral side post-operative, and get a good satisfactory things. So patella mal-tracking is common. Even after doing all these things, it's very tight, then rather than releasing the LCL, doing anything to the collaterals, you do the lateral sliding osteotomy, try to bring the lateral condyle below and try to match the one which is tight on one side and try to make it rectangular like this, and put the screw fixations after cementing. So this is the sliding osteotomy what we do. This is an example of that. In the many a time the non-correctable valgus you have to do that. But as I said, some cases are there where you can see this AP X-ray, the patella is on the lateral. It looks like a lateral view, and it's a dislocated patella. If you are dealing primarily with this type of cases, sometimes you have to go for a lateral parapatellar approach rather than the medial arthrotomy. And lateral parapatellar approach, as I said, you have to be careful. The releases are quite good, but the closer you might have to use the fat pad flap. So you have to be very careful about that. But this is the indication where we do that, and you can achieve a good nice closure. As discussed earlier, in other joints you might have to use a constraint prosthesis, or if your MCL is incompetent, to start with, go for a hinge knee like this. The last slide. The extension balancing is with a soft tissue inside out technique. The structures we said, do not cut LC or right or popliteus. Flexion balancing is by rotation, do the parallel tibial cut technique. When there is a major extra-articular deformity, Hemant is going to correct, I don't talk about. Bone deficiency, we all know, screw, augment, with, without rod. Patellar malalignment, you can do outside in technique. And when there is a non-correctable fixed valgus to start with, you can consider the lateral approach or sliding osteotomy. Thank you.